Hi, everybody. Welcome back to our study club sessions. As a continuation to our November 8th introductory lecture, we will be discussing the live surgical case that is available for observation and will be live streamed on November 29th from Apple Dental Specialists in White Rock. Now, this is a full upper arch case that we will be performing live for our participants. We will discuss the case going forward today. With the rationale of why we chose this option for this patient, what made sense, what doesn't make sense, go over some medical notes, some radiographs, CBCT slices, as well as a dental or a smile design protocol that we used for this case. We are attempting that we will do the extractions, implant placements, multi-unit abutment placement, and post-operative scanning all in one go. A 3D printed arch, a full upper arch, will be installed after the surgery on the same day, proving the concept of teeth in a day or all on X upper arch. So let's dive right into it. We have this 59-year-old man who is a relative of one of our dental professionals that we work with closely. He is a business owner. He's a landscaper by profession, immigrant to Canada about 20 years ago, built up his life, spent most of it in a struggle to build everything from scratch, and did not have much time to pay attention to his own personal healthcare needs while he was providing for his children. So we have this healthy 59-year-old man who has multiple missing teeth in his upper arch and lower as well. Now, his problem has become a pain point. He is unable to chew his foods properly, can't enjoy a quality of life to a satisfactory level, and they hurt. It's hurtful for him. In his relevant medical history, we have a hypertensive status, which is well controlled with medication. And what would be the considerations for that? If we go back to our pharmacology, we understand that any patient who is hypertensive or on any type of cardiovascular drug protocol, we would like to, in an ideal world, we would like to limit their exposure to epinephrine. That is one of the considerations that we have. Furthermore, we would also like to limit their exposure to non-steroidal anti-inflammatory drugs because they can cause thinning of the blood and as a secondary effect can cause hypertension. So we would like to avoid that, or if we can't avoid it, limit the use of both. So we can discuss that further in our study club sessions on what to do and how to do it. In his dental history, we have history of heavy smoking. He used to smoke up to 2 packs of cigarettes a day. It reduced to occasional and social smoking in the last couple of years. And he has quit since August 2025, right after our initial consult when we discussed the possible consequences of continuing smoking after a surgery like this. He does not drink and does not partake in any recreational drug use. So, what are his expectations? The key point that I can't stress enough: listen to your patient. Your chief complaint is going to come through in the patient's own words. Furthermore, you have to really align your clinical skills, your clinical outcomes with what the patient wants. Sometimes we get into a area of crossroads where we might have a slightly different clinical opinion from the wants of our patients. In that case, the wants trump our personal clinical opinion unless what the patient wants is going to be harmful for them. So we are not going to go, barring any malfeasance for their case, we are going to go with what the patient wants if it aligns with our surgical clinical beliefs and if it does not cause any harm, like I said before. So his expectations are reduction of his pain and discomfort, Aesthetics are also important to him. He does not feel too confident smiling and interacting in public or in family occasions. Restoration of function is a big thing for him. He has lost his ability to eat properly. We will see in the pictures upcoming how his bite has been affected, and that does create a pretty fairly difficult scenario for him in his daily quality of life and daily function. Okay. He leads a busy life. He's a business owner. He's a landscaper, very physically demanding, personal time demand on his work. So his desire is also to keep his clinical visits to a minimum. Okay, it's a very important key point. Because of these things, he has found it hard to focus on his healthcare, oral healthcare before. Now he's coming to us because of his recent reduction in hours to find a better work-life balance for himself. So now that he's has a little bit more time on his hands, he's been able to think about what do I want for myself? And now he is coming in to get this treatment. His daughter is a former CDA and still works in the dental industry, and that is how we got connected. And she has been a massive motivational factor for him to pursue this type of a treatment. Upon the clinical examination, we found that he has multiple missing teeth, overall neglect of remaining dentition, multiple restorations. We found that there was grade 2 mobility, grade 1 to 2 mobility in several of his teeth. On the extraoral findings, we see that he has a fairly symmetrical profile. I could not perceive any TMD or TMJ malfunction. He has reduced vertical occlusal dimension due to loss of posterior support. He is missing molars in quad 2. He is missing the molars in quad 3 as well. We will see some pictures in the next few slides. Soft tissue findings include moderate perio disease with multiple mobile teeth. Some bleeding off and probing was found around teeth 1.6, 2.1, 2.2, and 2.5. These are further pictures. We can see in the top right picture how the bite has collapsed. There is no posterior support. And if we just consider what we see here in the top right photograph, we will notice that we don't really have much prosthetic room. So we do have to open up the bite considerably to accommodate a proper set of teeth here, as well as restore the bottom missing edentulous spaces with implants in the future. We will see if we can actually do that on the same day, but for now, our plan is to focus on the upper arch, and then we go on to the lower arch at another day of the patient's and mine availability. So on the extraoral pictures, he has a lowish smile line. We don't really see a lot of the gum except for around the 1.3, 1.4 area. We have a little bit of papillary show. Others are not that visible, which is our advantage. This is the broadest smile he gives at this moment. We do always take bite registration pictures with retractors to allow us to visualize the midline and the bite as it sits currently and to help modify it if required. The radiographic findings are up next. We did take a CT scan of him. On the left, we see a full profile of the upper and lower jaws. On the right, we see a radiographic imagery of it, panoramic, so you will. The sinuses look fairly clear. On the left sinus, I do notice a pseudocyst or mucus retention cyst, which is inconsequential for our case. The patient did not exhibit any ENT symptoms related to this finding. So now we will see what the x-rays or what this looks like on this video of the CT scan here. I would focus on the top right and the bottom right screens here. We will look at a different layout of the CT scan as well to go over all the specific areas. My plan is to place my goal is to place 6 implants in strategic areas and get high anchorage. We can see here that tooth number 1.6 has lost significant amount of bone. and this bone gets quite narrow between the 1.4 and the 1.6. Then we move on to the anterior areas. Most of the teeth have minimal to no buccal wall, buccal bone, and that is contributing to the loss of periodontal and bony support and causing mobility issues in those teeth. And that is why I feel that these teeth are not really viable for long-term restoration. Remember the key point where he said that he would like to keep the visits to a bare minimum? Now, if we were to consider that we try and save all of his teeth, or most of them, or some of them, with a multitude of treatments like a few implants here and there, some restorations, periodontal conditioning, periodontal support, he would have to be in and out of a dental office for a very long time, as well as the foreseeable future, with visits every 3 months for just the perio part, then multiple visits for restorations, crown and bridge work. It adds on quite a lot. These options were discussed with him, and he explicitly chose to go with an implant supported option. We will look at these videos as well just to verify everything we saw before. Not much different than what we have seen in our previous videos. Now, we did, like I said, we did discuss multiple options. We discussed the option of leaving it as is, no treatment. Risks were discussed with him. Partial dentures only, replace what's missing, keep what we can. We discussed the possibility of bone loss in the non-supported areas and further risks of periodontal disease on the abutment and support teeth. Bridges as an option. Now, when we consider bridges, we need to have very healthy abutment teeth. His teeth were not absolutely healthy to be able to support bridges with grade 1 and 2 mobility in most of them. Then we landed on the implant option as a fixed and long-term solution, which we did receive a lot of support for. So once again, our plan is to do immediate implant placements after extraction of all of his upper teeth. We are planning to place between 4 to 6 dental implants. I will place bone grafts in the sockets and where else required with PRF. We will place multi-unit abutments, multi-angled abutments to correct the angulation of our implants, post-operative scan with a photogrammetry and intraoral scanning system, and we already have a design of his dentition in mind. We have designed it. The only factors that change is that we will align it to where the implants end up. That will require some changes and modifications to the design, but it also saves our post-operative time for design requirements. So we will design, finalize that, print the temporary prosthetic in office, which you will have an opportunity to see, cure it, finish it, and install it on the same day. This constitutes a smile design for us. This is how I was designing the case. These are my tentative implant positions. They're not set in stone because I don't know what my situation would be when we go intraoperatively if my situation changes. So we remove the teeth. We look at the bite. We overlay with a proposed treatment plan of how the teeth could look like. Now, this is considering his current video. We will raise the video slowly with the first temp. I plan to do a second or a third temp prosthetic as well, and we will gradually open his bite and get his masticatory musculature habituated to it rather than open it up all at the same time and create problems where our prosthesis can fracture. You would notice that my posterior most implants have a steep angle. That is to increase our anterior posterior spread. This is a plan based on 6 implants. From the looks of it, this would be akin to an FP1 style prosthetic, which means that we are planning to only design the teeth aspect of it and not have any gingival contours involved in our final restoration phases. Now, this is all our preliminary plan. This is based on imaging, what we saw, the measurements we took, everything else. These things can change when we start operating, and the intraoperative situation guides our hands into our final placement of implants and final outcomes as well. So we will go off to execution now. You will all have an opportunity to see this case live at the Impacted Global YouTube channel, as well as the people who are participating live. They will have the opportunity to view it in person. I hope to see you there and continue learning together. Have a good day. Take care. Bye bye.